Hello everyone, my name's Professor Andrew Wardley. Some of you know me, and for those of you that do not, I'm a breast cancer medical oncologist with over 30 years experience and over 300 peer-reviewed publications. I was involved in all of the trials that have led to major changes in breast cancer drug therapy, and I represented clinical expert opinion to NICE to get these commissioned. In my time, some of the opportunities afforded to me was mentoring many of the medical oncologists and breast surgeons in the UK and internationally. Some of these are still practicing. I've led provision of better local services, community services, and also interacted with NHS England to ensure that national services are improved. I've done a fair bit of work trying to address the deep-rooted challenges of the NHS that, although not intentional, restrict access to patient treatment and the best opportunity for care. Today I want to talk about MDTs. MDTs are multidisciplinary teams. These are a team of people involved in the treatment of a patient with cancer. For instance, surgeons, radiologists, radiotherapists, chemotherapy doctors. They come together to ensure that the right choice is made for the patient before treatment starts. This is often done in meetings. These are called multidisciplinary team meetings. Their introduction in the late 1990s greatly improved cancer treatment, because before that, many of the decisions were made by the first person who saw the patient without considering all the options. The options, as you probably well know, have become far more complicated over the last 30 years, and we're very lucky that we've managed to develop lots of new treatments that are hugely effective. The timing of when these are given is also important. We also have very standardised protocols and pathways now, so to follow those is much easier than it was in the 1990s. Unfortunately, over this period of time, MDTs have become an arena that patients are discussed in, primarily in meetings rather than in a more fluid way, because everyone is overstretched. This can lead to delays in decision making and delays in treatment for the patient. Also, MDTs are not always structured in the best way for the right decision making. It's clearly a different decision and a different process and different people who need to be involved in deciding treatment for someone in whom their cancer has spread compared to those in whom the cancer is still early. Reorganising MDT so that they're more efficient is clearly an important thing for us to do. To get the right team together, to be chaired, have a clear agenda, and putting the patient at the centre of the decision-making process. Interactions out of MDT meetings are also part of the MDT. We just need to remember that these need to be documented properly. And to all my colleagues out there, documentation about any patient care activity is essential. So keep your notes clear, concise, and relevant. Should you find that MDTs are not effective and you would like to discuss ways of improving these with an experienced oncologist, you can contact me via contactus@cancerservices.co.uk. Thank you for listening to me.